So I'll just take this opportunity for a couple of minutes about our project ECHO. ECHO is basically extension for community healthcare outcomes. It was a movement which was started in 2003 and University of New Mexico, Albuquerque by Professor Sanjeev Arora. And the idea is simple: moving knowledge fast. We want to reach out to every nook and corner of the world. Rather, now it's a global movement involving multiple countries and over 500 hubs all over the world. And we have been holding hepatitis ECHO in Pakistan. The PARSA, on behalf of PARSA Trust, we are the members. PKLI is one of the hub. Dr. Arif Mahmood Siddiqui is also joined. I can see him. And Aga Khan University is one of the hub, and National Institute of Health in Pakistan is also one of the hubs. Our hepatitis ECHO, there is an advanced liver disease ECHO. We had a brief stint at diabetes ECHO, and also advanced endoscopy ECHO. So these are the ones which are regularly running. And with the COVID now, things have gone really very fast. We have now over 200 participants. Professor Adeel doesn't need any introduction now. I think he is now a household name in Pakistan. He has spoken to the corporate bosses here in Pakistan, and then he had a talk for general practitioners. He had a community talk with him, and we had another talk in between. Today is a very, very important topic about post-lockdown. How are we going to deal our clinical practice? This is specifically aimed towards general practitioners who are really anxious. How are they going to start? What challenges they will be facing? And on Sunday, again, we are holding another session with Pakistan Dental Association, also involving the ENT people, anesthetists, and this time we will be focusing on aerosol generating procedure. Another thing which is going to haunt us in this post-COVID era, and this thing is gonna stay. So what precautions we will be taking, what are the recommendations, and of course it's going to be an ever-evolving subject. So Professor Adeel, I'll be handing it over to you. If you can just tell us more about yourself, and then you can start your presentation. We are nearly 250 participants, and more will be joining in because I do not want to delay it further. It's 9:05 p.m. and I will be very interested in the question and answer session after your talk. Over to you, Dr. Adeel.
Thank you very much, Asad. सबसे पहले तो तमाम सामीन और नाजरीन को अस्सलाम वालेकुम और बहुत-बहुत शुक्रिया आप लोगों का कि you have taken time out to listen to this. It seems like there is a tremendous hunger for knowledge regarding COVID-19, which is evidenced by the fact that the number of participants at each of the session goes up and up every time we do this. And kudos to Asad and his team, who have done a fantastic job of putting this together. I will start my slide set, and Asad, if you could just give me an indication that slides are projecting correctly.
Yes, we are good. If you can go on to this. Yes, we are good.
Okay. So today we will be talking about managing clinical practice in the era of pandemic COVID-19. And my brief introduction is that I work in infectious diseases in clinical practice as well as global health policy and planning as well. So I'm advising some governments, currently the government of Qatar, on the management of COVID-19, where I spend most of my time. But I've worked in 5 continents in global health and infectious diseases. And I'm immensely grateful to Asad and his team that they repeatedly asked me to come and speak to this wonderful group of people in Pakistan. So I do not have any disclosures related to my talk, but I do request all people who do not have essential work outside their homes to stay at home so that doctors can do their work and nurses can do their work and allied health professionals can do their work and save lives. So pass this message on to all other people as well, please. So what we will do today is we will go through a brief history of coronavirus, maybe just 1 or 2 slides, another slide or 2 about the epidemiology of the current outbreak, and then we'll spend most of our time around how the disease spreads, short presentation about the current treatments, and I'll be happy to answer more questions about treatment modalities if there is an interest. But we'll spend a fair amount of time about changes in practice settings and behavior, and how do we decrease the risk of infection and spread if and when you need to open your clinical practice or clinics. So a brief history of coronaviruses is that they have been around for a very, very long time. These viruses often infect animals, but 7 of these viruses have been known to infect humans. 4 of them cause mild disease and do not cause large-scale epidemics or pandemics, but 3 of them have been associated with larger epidemics and cause severe and sometimes fatal disease. And these include SARS coronavirus, MERS coronavirus, and the current novel coronavirus, which has been named SARS-CoV-2. And I just give a comparison of these viruses out here to give you an indication of how serious this pandemic is. And this is actually a slide from about a week or 10 days ago. And you can see that the number of cases was less than 1 million at that time. And the next slide, I'll show you the number has now crossed 2 million cases worldwide. So COVID-19, which is the disease caused by SARS coronavirus 2, is more infectious than all other 3 viruses, more infectious than influenza, SARS, and MERS. It is more lethal than influenza. However, it is less lethal or less fatal than SARS or MERS. So current case fatality rate globally is around 4% or so, which is 10 to 50 times higher than influenza virus, but less than MERS-CoV and SARS-CoV. So about 1 hour ago, I looked at the most recent numbers. The total number of cases worldwide is more than 2 million, and more than 128,000 people have died. And in the last 1 hour, I think this number must have gone on by another few thousand. And you can see here that the graph is still going upwards in terms of global incidence. And on your right-hand side, you can see that after the first 10,000 cases were detected in most countries, 1 country stood out in particular with increasing number of infections, and that is the United States of America. This is a quick summary of number of new cases per day around the world. And the reason I show this is because I want to drive home the message that infection control and public health measures do work. And that is what you will need to do if and when you open up your practices. So on this side, let me try to get a pointer out here. Here you can see the early days, early 4 to 6 weeks of the epidemic. Most of the cases here were in China, but very quickly they instituted public health measures and brought the number down. Then there was a period of about 2 to 4 weeks or so, right here, where the world was caught sleeping. We did not take it very seriously, and we saw a very rapid increase, an exponential increase in number of cases. And fortunately, it has started to plateau down a little bit, but has not started to go down. The situation in Pakistan may be very familiar to you. There are about 6,000 cases right now. The number of new cases is steady. And the reason I think it is steady and not going up exponentially is because of the number of tests being done in Pakistan. If you do larger studies of population-based screening and sampling, this number may be much higher than what it is right now. So how does the virus spread? Because you will have to keep this in mind when you open your clinics and practices so that you minimize the risk. The virus does stay viable and alive on many surfaces for a long period of time. So an earlier study showed that on copper, the virus you can detect viable virus up to 4 hours after the virus has been deposited out there. On cardboard surfaces, the virus can live up to 24 hours or so. On plastic and stainless steel, live viable virus can be detected up to 2 or 3 days or longer. What is worrisome is that in aerosols, it can still be alive up to 3 hours or so. And the reason this becomes important is If you have a person who comes into your room, even when you're not there, and the person leaves and you come in an hour or 2 or 3 hours later, you may still be exposed to those aerosols with the live virus in them and get infected, even when the infecting person is long gone. Another study was published about 2 days ago or 3 days ago. This looked at and confirmed some of the previous findings and extended them. They also looked at viability of the virus at different temperatures. At 4 degrees Celsius, the virus can survive on most surfaces for more than 14 days or so. At 22 degrees centigrade, which is what we consider general outside ambient temperature, the virus can live from 1 to 2 weeks or so. At human body temperature for 1 to 2 days, if you go up to 56 degrees centigrade, the virus can still live between 10 and 30 minutes or so. You need a steady temperature of 70 degrees or higher to reliably kill the virus and have a dead virus in less than 1 minute or so. So you can see from here that summer coming along very soon, and using gargles with hot water or blow drying hot air into your face will not kill the virus. And ambient temperature, at least the one we can tolerate as human beings, will not kill the virus. This study also looked at other surfaces. For example, on paper, it can survive anywhere between 30 minutes to 3 hours. On wood and cloth, up to 1 to 2 days. On banknotes, from 2 to 4 days. Steel and plastic, up to 1 week or so. It can also be detected on the mask that you wear. On the inner side of the mask, it can be detected for 4 to 7 days, while on the outer surface for more than 7 days or so. What you also have to consider and worry about is asymptomatic carrier transmission. And in some cases, in some countries, it is being postulated that about 1/4 of the infections are being transmitted by asymptomatic carriers. So this becomes very challenging. How do we identify people who don't show any symptoms but may still be transmitting the disease? And as healthcare workers, we always have to be careful and worry about catching the infection ourselves. And this is a neat study which looked at the risk factors for healthcare workers of catching or being infected with COVID-19. Very interestingly and strangely, if you have a patient who's diagnosed with COVID-19, you do not have a high risk of getting infected. In fact, you have a much lower risk of getting infected with COVID-19. You have a far higher risk, about 270% higher risk, if you have a family member who has been diagnosed with COVID-19. Similarly, if you do not wash your hands or sanitize your hands before a patient contact properly, you have a 3-fold or a 310% higher risk. And if you do not use your PPE properly, you have a 282% higher risk of getting infected with COVID-19. So I think the reason for this, the way I interpret that, is when we have a diagnosed patient, we take very high level of precautions, extra precautions when we go and see the patient. We drop our guard when we are back home, and we do not take all those strict measures and precautions. This is something I'll talk about at the end of the presentation, how to prevent or protect our families as well when you come back from your clinic. There is a big talk right now about whether everyone should wear masks or not, whether it's in the general public or in your clinic. So initially, when the epidemic started, WHO and CDC were not advocating the use of masks by everyone. However, now the number of cases worldwide has gone up to a level that masks are important to wear by everyone who comes into contact with other people. These masks, even surgical masks, do prevent detection of live virus. Whether they prevent actual infections, that study has not been done, but definitely lesser virus is detected if people wear masks, even when they're surgical masks and not N95 masks. So this goes on to tell us that we should generally wear them when in public places or when we come into contact with other people. One thing to remember is that masks are better for people who have symptoms of infection or who are infected, for them to prevent transmitting to other people. They're less effective if you are asymptomatic and uninfected from getting infection from other people. But still, I think they provide some degree of protection that we should use. How do the cases present? How do we diagnose them? Fever is the most common symptom, and at some point in their infection, about 90 to 98% of all infected people will demonstrate fever. The second most common symptom is cough, which is seen in about 68% of the cases. Everything else is less common. So when you're screening patients who come to your clinic or your staff, I think fever and cough become two of the more important things, although other things can be taken into account, but fever is the most common symptom by far. Diagnosis of COVID-19 is by a nasopharyngeal swab. Lower respiratory secretions like bronchoalveolar lavage fluid is much better at detecting COVID-19, but we do not recommend that routinely unless there is no other option or you need to do it for some other reason. And the reason for not recommending a BAL or bronchoscopy is because it is a very high-risk procedure for the persons doing it. They are at a very high risk of catching or getting infected with COVID-19 because high levels of aerosols are generated during the procedure. The virus is also found in sputum and also in stool. However, we do not know if stool is a means of transmission of infection or not. Other assays are now available. For example, serologic assays, which detect IgG and IgM. These are rapid point of care assays. Result can be available within 30 to 45 minutes or so. However, the problem with these assays is that they're not positive early on in the disease. They only become positive 5 to 7 days after the person has been infected. Even if they become symptomatic early on, they may not have the serologic test positive. So they're not useful in detecting early disease or when you're trying to prevent transmission from carriers to other people. How do you treat this? So first of all, almost everything that you come across on social media is incorrect. Kharbuzas or your Pir Saab's taweez or Pir Saab's other totkas, Gau Mutar as being touted in India, gargling with warm or hot water, blowing hot air by hair dryers onto your face, none of these is going to kill the virus. What we know so far is that a few drugs have a possible role, and these include chloroquine azithromycin combination, convalescent plasma or serum, the antiviral called remdesivir, and in a specific group of patients who are in the ICU, IL-6 receptor blockers like tocilizumab. Remember, none of these have been shown in properly, strictly done randomized clinical trials. All the data that we have so far is on a very small number of patients, generally uncontrolled without any randomization or so. So while there is a signal that some of these might work, they are far from being accepted as a standard of care or being approved by any of the drug agencies. Some other reports about ivermectin, which is an antiparasitic drug, have sprung out. Ivermectin data is only in cell cultures, but not in humans. How do you prevent it? So the two steps in prevention of COVID-19. One is preventing yourself from getting infected. And the second equally important part is, God forbid, Khuda na khasta, if you get infected, to stop giving it to others. And both of these need to be done to break the cycle of infection worldwide. And how do we break the cycle? I think you have heard this many, many times. Social distancing, which means no handshakes, no hugs, working from home as much as possible, avoiding places where a lot of people are gathered, like malls, restaurants, weddings, funerals, mosques, etc. And strict hand hygiene. These are the steps needed to break the cycle. Do these things or do public health measures work? I think China has shown very elegantly, and so has Korea and some other countries, and Taiwan, for example, and Singapore, that if you do these public health measures, including quarantine, self-isolation, targeted lockdowns, or larger scale lockdowns, you can actually control the epidemic relatively early on before it becomes too late. This is another slide showing that when they instituted the measures of quarantine, city lockdown, traffic suspension, etc., the case rates, incidence of cases dropped very dramatically over a period of about 2 weeks or so. So this is what we need to do in most places where the epidemic is still happening. So let's move on to the main portion of the talk, which is what do we do about workplace adjustments. So I think with the COVID epidemic, a lot of things are going to change, and hopefully change for the good and forever. So these kind of practices hopefully will go away. Roadside dentists, roadside barbers, roadside air cleaners, and so forth. These need to be done more hygienically and by controlled practitioners. So what should you do about your clinics? I think there is a wide consensus worldwide among public health authorities that all clinic activity should be minimized, and clinics should be open only for those who are in critical need of being seen. It is being suggested that you use technology wherever possible, like using telephone to triage patients, or seeing patients, or reassuring patients through video calls or telemedicine. And only if there is no other option, then you should open the clinics and start having patients in your clinic. But even then, you must take all precautions regarding infection prevention and control, and some of which we will go over in the next few slides. These are some of the things you should consider before opening your practice, and I've tried to lump them together in certain domains. So minimize chance of exposure for staff, patients, and visitors. And by the way, we'll go over these things as to what specific steps we should take to do that. Strict adherence to standard precautions, and you enhance those precautions whenever it is necessary or when the risk is higher than usual. You adjust patient flow and patient placement in your clinics. You control access and movement within your clinic or facility. You might want to add engineering controls. Again, we will talk about some of those. You must have policies and procedures in place beforehand for exposed or affected staff and patients. It's not a matter of if, it's only a matter of when you will see one of those patients or someone who starts showing symptoms. And you should have a mechanism of reporting cases to appropriate public health authorities. So taking these, I've put them into three large domains or areas where you may need workplace realignment to have a safer workflow. These are administrative controls, personnel controls, and engineering controls. So administrative controls include having policies and procedures for prompt identification of infected staff and patients. Whether you do it through triage or questionnaires or taking temperature, whichever way you do that, you need to have some way of identifying people who are at high risk or who may be infected. Wherever possible, you should have policies to work from home. If that is not possible, then we will go over some of the measures you can take to minimize the risk. For staff, you should have enough PPE. So this is an administrative task that you as clinic leaders or clinic owners should ensure that everyone who comes and works for you should have PPE provided by you as a clinic owner so that they can perform their work safely. Personnel controls include if you can separate all your patients and separate all your staff to safe distances, whether it is by physical distancing between them or by having them come in shifts so that they don't mingle with each other, they can work in different shifts, and by avoiding or discouraging use of other staff's equipment, phone, desk, or anything that other people may have touched. And some broad engineering controls include increased ventilation and airflow in your room. You can buy portable HEPA filters for your rooms, or if you have windows, you can keep the windows open. So as much airflow and ventilation as you can possibly do in your room. You should have enhanced cleaning and disinfection of the surfaces of your clinics regularly and repeatedly. Any equipment or any materials that you use, you should use approved products for that. And you may need to change the layout of your waiting room and your examination room in which you see your patients. So I've divided this into 4 steps for your clinical practice or your clinic. So at the center of this, or the core of this, is some general precautions, and then things that you do before the patient arrives at your clinic, things that you need to do when the patient arrives at the clinic, and things that you need to do when the patient is with you in your examination room. And there's one extra things that you need to do after the last patient has left, and how you will leave the clinic and go home. So we'll talk about that as well. So some general principles are, and some of these have been mentioned before, that work from home, have some policy around that. You must train your office staff at certain things: how to identify a patient at risk, how to triage patients when they're coming in, to see if they may have infection or at a higher risk of infection. You should also have some pathway or plan of screening of your office staff from time to time, whether you do it by asking them if they have symptoms, or taking their temperature, or every once in a while doing a nasopharyngeal swab of them to make sure that they're uninfected. So the policy will depend and vary from clinic to clinic, city to city, depending on the risk in your particular area or locality or your city. But what is imperative, what is very important, is that you must have a plan ready when the first patient or staff becomes symptomatic or tests positive. And these plans should include: how would you transport this patient or staff from your clinic to an appropriate place, whether it's a hospital or to their home if they're asymptomatic, or to a quarantine facility? How will you start contact tracing? How will you do counseling? You need to have a counseling plan in place, and you need to have a deep cleaning and disinfection plan for your clinic and every surface that these people may have come into contact with. Before you open your clinics, you need to identify isolation facilities, either inside your clinic area, if you have multiple rooms, or somewhere nearby where you can put the patient while you're transporting them or while you're evaluating them. Another general principle of people who are wearing masks is that we often have a tendency of touching the mask when the mask is on. If you touch the mask on the outside, you lose the purpose of wearing a mask. So do not touch them. If you have some unavoidable reason that you end up touching, sanitize or wash your hands every time you touch your mask. So going on to those other three outer circles, so even before the patient comes to your clinic, I think you should develop a checklist of things. And you can copy this into and write this on a piece of paper as a checklist and institute that or have your staff do that. You should probably see patients by appointment if at all possible. And when you have appointment patients, call them before they come to see if they have any symptoms of COVID-19, which include fever, cough, sputum production, shortness of breath, or if they've been in contact with someone who had COVID-19. On this phone call, you can also do a quick triage. You can determine the need and urgency of the visit. If the visit is not urgent, you may take care of them on the telephone. But if you determine that they do need to come in, you can do some education right there and then. You can tell them that you should, if you have to come in with a mask. You should wear a mask when you come to my clinic. You should tell them about new rules and etiquette of your clinic, that when they come to your clinic, they should stay away from other people. They should not shake hands with anyone, and maintain safe distance from your staff and from other patients if they're there. You can space appointments, minimize number of persons in the clinic at any given time, limit entry points into the clinic to 1 or 2, as few as possible. Perhaps ideal would be 2, 1 for coming in of patients, 1 for going out, but if that is not possible, 1 is fine. If the clinic waiting room is too small, think about an outside open space where you can put chairs with safe distance in between them. When they arrive at your clinic, and before you see them as a doctor, the few things you can do to decrease the risk and help your patients and your staff. Put up signs and posters which tell patients about the signs of and symptoms of coronavirus disease. How could they prevent, like cough etiquette, like putting on a mask and so forth. You can also leave educational materials like leaflets. If you have a television and a video recorder or a DVD player in your office or your waiting area, you can play some instructional or educational videos out there. You should make sure that there is enough sanitizer at every entry point into your clinic or office, or hand washing stations where patients and staff can do hand washing or sanitize their hands. There should be masks. If patients are not already wearing masks, they should be asked to wear one. You should limit the number of attendants coming into your office. In Pakistan, it is very common to have like 3, 4, 5, 6 people come with one patient. you should have a policy of not allowing anyone, perhaps at the most one person could come in with the patient, but if it could be no person, that would be even better. If they're children, of course, they might need to have at least one parent present, or if they need a chaperone, for example, if you're examining a female patient, they may need one female person with them. Your nurse or your frontline staff can do a quick triage again, ask for symptoms, take a temperature, ask for history of confirmed contacts. And if any of those are positive, they should be separated from everyone else. You can also install physical barriers like glass or plastic screens for your cashiers, for your appointment clerks, for your secretaries, so that they don't come into direct contact with any coughing or sneezing from the patient. If anyone is coughing and sneezing, they shouldn't be in your clinic in the first place. They should be triaged very rapidly and moved out to another area. If it is a possibility, you try to have a triage station outside your waiting area, as long as it preserves patient confidentiality and is not too inconvenient for the patient. And for your staff, at least you should have enough supply of masks and gowns if they're required, depending on the type of your practice, and sanitizers. So when the patient comes into your room for you to examine, try to make sure that there's only one person in your room at any given time. Try to limit the number of attendants coming in with the patient. At the most one if it's absolutely needed, or no attendant if it can be done. Both the patient and you as a doctor should have the mask. If you have a nurse with you or another assistant with you, they should also have a mask. If you are examining the patient, and particularly if there is suspicion of COVID-19 or the patient is symptomatic, then you should do more protective gearing. And I'm going to talk about that in the next or couple of slides. You should also consider wearing a gown, an eye shield, and head cover and shoe cover. If your room is spacious enough, try to have a distance of at least 6 feet, except of course when you're examining them. But if when you're examining them, you should take all the necessary precautions of gloves, and possibly an isolation gown and mask and shield. You can minimize the exam to what is necessary, and you should disinfect every equipment that comes into contact with any patient, like for example, stethoscopes, otoscopes, or any other thing that touches the patient. You should do that. You should disinfect them between every use. Try to use disposable items whenever it is possible and discard them appropriately according to correct infection control practices. So this is the full protective gear. If you have a patient who is suspected of having COVID-19 or patient who is symptomatic or confirmed. Confirmed patient in a clinic setting should not be seen, in my opinion. They should immediately be transferred to a facility where they can be taken care of. But this tells you about wearing a mask, eye shield, head cover, isolation gown, gloves, and don't forget shoe cover. There was a study done in which virus was detected on shoes of doctors and healthcare workers. Sometimes we sneeze and cough, and or others may do that, and the aerosol may be in the air and settle on your shoes. So after the clinic is over, what do you do? So what I recommend and what other people have recommended is use separate clothing for your clinic and hospital. That includes both clothes and shoes. When you leave home, change into work clothes when you get into your car or before you get into your car. Again, you can wear scrubs as well as separate pair of shoes. And when you come back home after clinic, change again into home clothes and leave your clothes and shoes either outside the home, in the car, or in some other area where they will not come into contact with anyone in the house. If it is possible and you have the facility, get a thorough warm shower with soap before you touch anyone in the house or any surface in the house. What should you do if a staff or a patient tests positive in your clinic? You need to immediately isolate the case or the staff member. You need to evaluate that person for presence of symptoms of pneumonia or severe disease. And if they have those symptoms, they should be transported to a hospital. You should do a full deep decontamination of all services this person may have come into contact with. You may need to close your facility or clinic till all contacts are traced and all surfaces have been cleaned. A thorough contact tracing is mandatory, and even all contacts who possibly came into in close proximity of this confirmed case need to be isolated and quarantined based on existing practices. So this is my second last slide. So some larger perspective here. Do we see any hope in the near future? And I think for the first time in the last week or two, I've begun to see a flattening of the curve, not decrease in every area, but at least a plateau in the number of new cases being diagnosed, even in the US. So after an exponential rise in all these top 4 countries, the cases have started to stabilize. And this is because of strict isolation, quarantine, and lockdown measures, and avoidance of mass gatherings or avoiding places where people generally congregate. So this gives me hope, makes me optimistic that if we do that, we might stem the tide a little bit. But remember, even when you do those very aggressive measures, it takes several weeks to get to a steady state level. The curve hasn't started going down reliably in every country. It's still at a steady level. It'll take a few more weeks to start to go down. But that should not make us complacent either. So in summary about opening clinical practices, clinics should be minimized whenever it's possible to those that are absolutely necessary. And if necessary, take as many precautions as you can among the ones that we have just discussed. Make sure you educate your staff and your patients. You triage them before they come to your clinic and also when they come to your clinic. Plan in advance for all possibilities and contingencies that cases will happen among your staff and patients, and you should be ready for that. Do not become complacent. Do not think that things are getting better till they actually have gotten better. So I'll stop here, and Asad, I will hand it back to you. I'll stop sharing my screen and hand it back over to you for any questions and answers.
Thank you. Thank you very much, Adeel. Very enlightening as usual, and I'm really grateful for your time. I don't know how many presentations you have given since morning.
This is the third one.
So thank you. So